Hello and welcome to the ESCRS Forum panel discussion on refractive IOLs. I'm your host, Béatrice Cochener, and today I'm joined by Oliver Findl, Thomas Kohnen and Rudy MMA Nuijts. Welcome. Today we will discuss the keys to surgical success in astigmatism and presbyopia correction with cataract patients. We will describe the available presbyopia and astigmatism IOL treatment options and the ideal patients candidates. We will also discuss the importance of acquiring precise preoperative measurements as well as the necessary steps to take intraoperatively and postoperatively to ensure good visual quality, acuity, and patient satisfaction. The 2018 ESCRS Clinical Survey revealed that 7% of cataract procedures involve presbyopia-correcting IOLs. Among them, 56 use trifocal IOLs, only 20 use extended depth of focus so far, and 20 use still bifocal IOLs. So what type of patients are best for each of these of presbyopia-correcting IOLs categories? What do you think, Thomas, about these?
Well, if I report for myself, I have stopped using bifocal lenses because I think that the trifocal lenses, if you want to achieve near visual acuity, are better, because they have the intermediate, they don't have the intermediate problem. So in my practice at the moment, if I'm looking at the presbyopia correcting IOL, I have approximately 60% trifocals and maybe 40% extended depth of focus intraocular lenses.
Could we maybe even add that in terms of loss of light, these trifocal are very smart concept because we are not losing more light compared to the bifocal, which is also the key value of this, again, addition of a third dimension, which is the intermediate vision without compromising more the contrast sensitivity. You do agree on that?
Yeah, you made a good point, because the bifocal lenses really lost a little bit more than the trifocal, the new area, and that's also reflecting the patients. The patients still have, of course, optical phenomena, but overall the concept, because intermediate is done and the usage of light is better, though, so the satisfaction with trifocals is better.
And so finally, I know, guys, that you may be not as convinced as we are on trifocal lenses, maybe not as high user. Do you think that we can make a decision tree between the indications for EDOF compared to multifocal lenses, Rudy?
No, we just finished actually a randomized clinical trial comparing one of the most used trifocal lenses with one of the EDOF lenses. And basically the idea was that we would like to see whether a lower incidence of optical complaints would come up with the EDOF lenses, because it's one of the ideas out there in our fellow surgeons group. We were actually surprised to see that it was not the case. So in terms of incidence of adverse effects, the lenses appear to perform the same. And then what stands out is clearly, of course, the advantage that you have in terms of near vision, since the intermediate vision was comparable between the two lenses. So in my practice, we tend to have a clear, preference for trifocals above EDOF lenses at the moment. Yeah.
Do you think that it might be related to the fact that we are for all the EDOF, targeting for mini monovision, that will, by the fact that we are leaving some myopia, will induce some halos?
No, so we had in that study, actually, when we looked at it, there was some mini monovision in that EDOF group, which, let's say, narrowed the gap between, for near vision, between the two types of lenses. So you can make up a little bit the difference by taking that approach. But still, I think if the incidence and side effects is not really different between the lenses, what is the additional value then? I think we haven't seen very good data on that.
What about your opinion, Oliver? Do you think that we can define a strategy of choice between EDOF and multifocal lenses?
I think I think the point is well taken. That we know that EDOF lenses also cause dysphotopsia, so they also have halos and glare. I found in especially compared to bifocal lenses, I must also admit, so to lenses which I don't use anymore.
We have skipped. I think all three of us have skipped.
We've sort of skipped that, yeah. But there's no question that these dysphotopsia with EDOF lenses are much less intense, and therefore the patients, at least let me say in my hands, didn't have to explant a lens yet, an EDOF lens, I mean. I think EDOF lenses have one positive sort of effect, and that is that they may be a little more let me say, you have a little more room for if you have refractive outcome problems. That means you're a little off zero, or you have some residual astigmatism especially, or maybe even an irregular component of astigmatism, like in a dry eye patient or something.
You're more tolerant.
You may have more tolerance there than you have with the trifocal. So in my hands, a trifocal really needs to be pretty spot on for the patient to be very happy and satisfied. Now, there are also patients who are a little off and still satisfied, there's no question. But I think with an EDOF lens, you may have a little more leeway. That's the one thing. And the other thing is, I don't know, there's no good studies on this, to be honest, at least not that I know of. In high myopes, so patients, you know, who maybe need just a 10 diopter lens or 12 diopter lens, bifocals have never worked very well for me, and also trifocals, my results were not that great. But I don't have a systematic way of showing that. And in these cases, I often had EDOF lenses with a little monovision, even 0.75 or 1 diopter. And actually, my experience is pretty good in these patients, these myopes, and these high myopes with EDOF.
But certainly, if you have a gap of -1, you close a lot of the gap. If you are target for -1,
but I think also, but EDOF, you know, we also sell EDOF differently. So I don't tell the patient. I tell the patient you will need reading glasses for long time reading, for small print reading, and for bad illumination. And they know that from beginning on. And these patients may also be a little less risk. You know, adventurous or be risk adverse. So that means these patients, I think with EDOF, it fills a nice gap for me.
But that counts for both categories, that you have to educate the patient on what they can expect.
Yeah, so let's come, by the way, on the key limitation of all these lenses. So